Here now to discuss some practice-changing abstracts in multiple myeloma is Dr. S. Vincent Rajkumar, who is Professor of Medicine and Consultant in the Division of Hematology, Department of Internal Medicine at Mayo Clinic. Hi, Dr. Rajkumar. Thank you so much for being here today at ASCO.
Thanks so much for having me.
Sure.
It's a pleasure.
Yes. So, first off, congratulations on being recognized as the 2019 Giant of Cancer Care in multiple myeloma. What are your thoughts on being recognized with this peer-nominated award?
Oh, this is an incredible honor. I couldn't believe it when I got the notice. Enclave has been selecting some truly great giants in the field of cancer, and to be even on the same stage with them is an incredible honor. Particularly thrilled that Dr. Rai, whom I've adored over like decades, was there to give the award to me. Yeah, well, very special.
It's very well deserved, so congratulations.
Thank you.
So moving on to some of the multiple myeloma studies that were presented at this year's meeting, there's the phase 3 Icaria MM Trial, which garnered a lot of excitement this year. So that was looking at the triplet regimen of isatuximab, pomalidomide, and dexamethasone. What are your thoughts on the results of this study?
So the isatuximab, pomalidomide, dexamethasone randomized trial is a trial that used a new monoclonal anti-CD38 antibody, isatuximab. We already have a monoclonal anti-CD38 antibody on the market, daratumumab, so this will compete with that if and when it gets approved. The study shows that isatuximab is indeed active, and patients who took the triplet had a longer progression-free survival and a trend for overall survival benefit. So I'm very excited, particularly for me, since I've been part of the study team. This is very great news that we have one more active drug, and more importantly, I think that I've always been a fan of having competitive drugs in the market, which may put some pressure on costs and reduce barriers for access.
That's a very interesting point. Okay. Now, the phase 3 COLUMBA study evaluated a subcutaneous flat dose formulation of daratumumab in patients with relapsed refractory disease. So how could these findings change practice?
Oh, I think the daratumumab subcutaneous formulation is going to be a very big plus. Dara has very quickly, from like the last 4 years, become indispensable in the treatment of multiple myeloma in all stages, from frontline, relapse, maintenance. And the main problem with daratumumab is that it takes 4 to 6 hours to give. And sometimes patients are getting it every single week or every 2 weeks. And it's a burden for patients. And the subcutaneous formulation, on the other hand, is only a few minutes, and like 3 to 5 minutes. And what we found in the study was far less, of course, infusion-related reactions, and also significant response rates comparable to what you get with the IV formulation. So there's no real detriment to the use of the subcutaneous formulation, only benefits. So I'm really looking forward for this formulation to be approved so that patients can have access to this.
Good. Now, part 1 of the Cassiopeia study that explored daratumumab in combination with bortezomib, thalidomide, and dexamethasone in newly diagnosed patients. So how could this regimen fit into the paradigm?
Oh, this Cassiopeia trial was my #1 abstract for myeloma at ASCO. Many reasons why. It's a more than a 1,000 patient study that accrued within 2 years. I mean, that's remarkable. It's not something that we can do in the United States. So the trial was conducted and led by the IFM group in France, and they looked at a 4-drug regimen versus a 3-drug regimen, testing the use of daratumumab in the frontline setting. What they found was, as expected, improved response rates, improved progression-free survival, but more importantly, there was also a trend for an overall survival benefit. Now, this is very critical when you want to use a drug like daratumumab early on. More than progression-free survival, if there's a hint of survival benefit, that really helps, and there was, and that's very impressive to me. Now, and in terms of how does this affect practice, to me, I think the concept that we may have to use 4 drugs to get the best outcomes in newly diagnosed myeloma has been established by this study to some extent. And so I would be ready to use something like that in a high-risk population. The only reason why I hesitate to use it for all patients with newly diagnosed myeloma is, number one, the study looked at only young patients who are less than 65 who are transplant eligible. So that's the group you want to go for. And secondly, the study used bortezomib, thalidomide, dexamethasone with daratumumab, and we don't use thalidomide as much. We use lenalidomide. So There are some data that will come out soon with a 4-drug lenalidomide-based combination, and I'll wait for that for some of the standard risk patients. And finally, a little bit more mature data on overall survival before I embrace it for all patients who are transplant eligible. But I think for high-risk patients who are transplant eligible, where there's so much to lose and so much to gain, I think like the use of a 4-drug regimen is something that I'm going to consider as, practice changing even now.
Now, what about in smoldering multiple myeloma? So there are smoldering myeloma. So there's a study looking at in high-risk disease at lenalidomide compared with observation alone. So can you talk about those data a little bit?
Yes, and so with smoldering myeloma, it's an asymptomatic group of patients. These patients, some of them can go for many years without needing any therapy. But on the other hand, we also know like 50% are going to progress within 5 years. And if you use some biomarkers to look for high-risk patients, we know that 50% will progress within 2 years. So if you have a 50-50 chance of getting a serious malignancy within 2 years, shouldn't we be doing something to try and prevent it? And that's what we did in the ECOG trial. We gave lenalidomide versus observation, and we found significant delay or prevention of end organ damage, such as renal failure, anemia, bone disease. And coupled with the Spanish trial, which has already shown the same thing, we think this is practice changing. The Spanish study also showed an overall survival benefit. So Dr. Lonial, who presented the study, myself and many of my colleagues in ECOG, we feel like the time for high-risk smoldering myeloma to start on some form of therapy is now. What should that treatment be? For right now, the best data we have is for lenalidomide or lenalidomide plus low-dose dexamethasone. We do have an ECOG trial that is just open, which is going to compare something mild like lenalidomide dexamethasone versus a more myeloma-like therapy with a triplet. And that trial is active, and when that trial results read out, we'll know whether these patients should be treated more in a preventive manner or full-blown myeloma therapy.
That's great insight. Now, what are some other multiple myeloma studies that are being presented this year that you were really excited about, and what do you think this really says about the way the field is going over the next year?
Oh, this was a very, very good ASCO. We had a lot of abstracts that were presented here for the first time that nobody had any data from before. One of the ones that I really was fortunate to work on, and to some degree, is the International Myeloma Working Group project on risk stratification for smoldering myeloma. Like if we're going to treat high-risk patients, how are we going to identify these patients in a manner that's uniform across the world, that everybody has the test to? So there was a study, over 1,000 patients were studied, and we have a very simple risk stratification model that simply uses the free light chain ratio, the size of the M protein, and the percent of bone marrow plasma cells to select patients for therapy. There was also another International Myeloma Working Group project looking at the natural history of 11-14 myeloma. Now, myeloma is really 6 or 7 diseases called together as one disease, but it's really 6 or 7 individual diseases. And for the first time, we've taken one of those, the 11-14 type, and studied it in detail. There's 800 patients were studied. We established what is the normal median survival, how do they respond to therapy, what other cytogenetic abnormalities will they get. So it's a start for the field to start looking at myeloma as individual diseases. Like we said in a recent paper, the multiple myelomas, rather than one disease. There were also a few new drugs that are active in myeloma that we heard data from. 2 of those were updates. One is the Amgen 420, that's the bispecific T-cell engager that has shown single-agent activity. We had updated data on that. That's very encouraging. The other one is selinexor, with unique mechanism of action, that also showing some survival signals. And then for the first time ever, we heard the data on the CELMoD, a new cell gene compound called CC220. This one is like thalidomide or lenalidomide in a way, but also quite different. And it was studied in patients who had already failed other treatments and shows, again, activity in combination with low-dose dex. So that's encouraging that we are getting even more new drugs for myeloma beyond the many, many drugs we already have. And finally, there was update of a large study that looked at various carfilzomib-based combinations, carfilzomib, lenalidomide dex given for a fixed duration versus continuous versus that regimen plus a transplant, the Forte trial. And this trial shows that transplant may still have value even now with the arrival of new drugs and many other options. So I think all in all, ASCO 2019 was a very good year for multiple myeloma in terms of new research, progress, new drugs. So I was very happy to be here.
Well, we're so happy that we had you here, and thank you so much. Really appreciate it.
Thanks so much. Yes.